Those who don't know me, which will probably be a lot of you, my name's Rob Moore. I'm from the Northern Territory PHN. It's great to be here, and I'd have to say on my behalf, it's been an absolutely fantastic couple of days. I've learned an enormous amount and really looking forward to taking that information back with me and sharing with my colleagues, certainly. And it's been great being able to network with a number of you. First of all, I too would like to acknowledge the lands in which we're meeting today and pay my respects to elders past, present and emerging, and also extend that to any Aboriginal and Torres Strait Islander people here today. Further to that, I'd also like to acknowledge the wonderful care and stewardship of all of the elders of the past that have taken such great care of this beautiful country and land. Friends, as you know, I know being one of the facilitators for a few of the tables that you were beavering away before lunch around a number of the questions that we have on the screen here, and this is an opportunity for that mind mapping work for us to be able to feed back as groups. So what I'll be doing is I'll be calling on some of the tables to be able to feed back their findings around those areas, the actions and the milestones that they sort of were able to discuss and elucidate during the session. The other thing that will happen towards the end of your feedback sessions as well, there's going to be a couple of people wandering around with microphones that would like to sort of ask a few of you questions as to how you found the mind mapping process as well. So they'd be very keen to be able to get that feedback and hear from you about how you found the experience also. But just kicking off, do you think table one's good to go? Table 1 and 2 came together. Hey, look, we'll play it by ear. It's going to be a one-man band. So this was on the mechanisms of collective action. If you'd like to share with us your findings, that would be great.
Okay, still half of our table's missing, but so do you want us to? So what about the shared vision, or is that something different?
Sorry. Top 3 priorities? Yep. Okay.
Okay. All right. So I'll just give you our vision first. So our vision is for a community-led action to improve Indigenous health outcomes, and so we chose 3 key stakeholder partner achieving outcomes. So the first one was centering around Indigenous voices and experiences. The second one was to have and improve on our health service so that we can deliver a more coordinated, collaborative health service. And the third one is a Central Australian Diabetes Centre of Excellence for delivering a multidisciplinary, coordinated, collaborative diabetes service.
That sounds
Did
great.
everyone hear that? And then moving on to key stakeholders or partners in achieving the first sort of goal, which was around Indigenous voices and experiences. You just want to
go to the top 3 priorities? Okay, that's good. Otherwise, we might not get through. Now,
Okay.
Can I just ask as well, we want to collect up all of these sheets afterwards? That's the goal? Yep. Excellent. Okay, so that was 1 and 2 together. Maybe if we move now, I don't know whether we had anyone on table 4, but table 3, access to drinkable water. Is anyone available to be able to talk to that one? Thank you.
Okay, thanks. The rest of the table took off, so you'll have to put up with me.
Another
Trying to read somebody else's handwriting might even be more interesting. So ours is access to drinkable water. And the first one we said was involve the community in how water is controlled as far as access, availability, quality, sustainability and needs. The other one was the decision making and planning and strategy for the control of water to be done by this Aboriginal committee in the community, comprised of elders and other community members. And the big other one is trust. Trust in the system is so important, where the communities have to be able to trust the quality of the water provided and the information regarding the quality that is provided by the water department and issues like that. Those are the only three.
Excellent. Thank you very much. Okay, I think we've got a combination for table 5 as well, around food pricing. I think there was quite a bit of discussion, I think, over there.
Yeah, there was lots of discussion. So I'm just looking here to work out our 3 top ones. Definitely we talked about aiming for equity in terms of food pricing between remote and non-remote areas. And this could take the form of some kind of subsidy, but that determining of that structure of a food subsidy or a way to be able to reduce the cost of food would have to be done in the Indigenous community, so making sure that there were opportunities for Indigenous leadership to determine that. We then talked about making sure that there was a holistic approach to food pricing and food costs, and within this recognising the importance of access to the traditional food system, which obviously is playing an important part for people's diets. And then we talked about the importance of establishing a store policy for pricing and marketing. So we thought that we couldn't separate addressing food pricing from not addressing the marketing of unhealthy foods. So establishing a store policy around both of these, and then making sure that we've got the structures in place for the monitoring, potentially the regulation, the benchmarking and accountability to make sure that there is equitable food pricing. But we also, just saw that this was a priority in terms of food affordability, to make sure that we're considering food pricing with income, that it's not food affordability, it's not just about food pricing, but that low income and people's accessibility to, say, Centrelink payments, etc., needs to be addressed, because there's lots of people that aren't able to, for whatever reason, able to access their Centrelink income. So, and also obviously the income doesn't match with the cost of living. Thank you.
Excellent,
thank you. Is that it, team? Yeah.
It'll be interesting as we go through these topics as well to see if there's overlap between some of these areas, as well as to how there's some synergies. So moving now on to, I think, I don't know whether table 7 was accommodated, but table 8 on local food production. Anyone from table, table 8, good to go.
So we talked about local sustainable food production and having that as a community-led project and activity so that it lasted through the generations. There was a lot of discussion around different communities that have tried it in the past, and for whatever reason it's fallen over because of ongoing funding and the ability to sustain it. So we need to bring it back to community level and engage the community members around owning the project and moving it forward for what suits their diet and their needs as a community for food sources. We also talked about encouraging foraging for bush foods and passing the knowledge on through yarning circles and intergenerational information, understanding what bush foods are appropriate and safe to eat and what should be avoided, and ensuring that people understand the seasons around when food sources are available and accessing that kind of bush tucker. And we also talked about farming and livestock and orchards and having a larger scale production of food sources for community use, and the possibility of involving more corporate ideas around buying back those products that are locally grown and sold through the community stores, rather than relying on food being brought in from other places that bring about food transport costs and so forth that increase the prices of food. So by farming it in local areas, reducing those costs as well.
Excellent, thank you. Just moving on to, I know the next couple of tables, both 9 and 10 looked at this one here, so maybe if table 9 kicks off with the transitions between schooling and Aboriginal employment opportunities. Who'd like to be the spokesperson from 9? Toss a coin.
None of us want to talk, so we spoke about the transitions beyond schooling and Aboriginal employment opportunities, and we spoke a bit about like traineeship programs and stuff, and we spoke about flexibility and remuneration, so having like a weekly pay as opposed to fortnightly, because that's not something that's very productive, or it's not sustainable within communities. And the goal of this program is to have some methodology implemented across the entire territory for as long as the program could run. We also factored into the health service budgets with the mentoring for trainees that cater for all styles of learning and include local key environmental place, a local key environmental place that offers the community a culturally safe place, and utilising all community services. Was that it? Excellent.
No, that's good. Well done. And on that same topic, table 10. And I know, being the facilitator for those few tables, there was some great discussion going on, so please share all of your ideas.
Awesome, cheers.
Thank you. So I just got dobbed in by the corporate and cultural knowledge holders of the Northern Territory Department of Health. They call themselves the ancient furniture and dinosaurs, but we've got, doctor here and professor here, so I'm going to make sure I'm keeping in with the kinship system and learning from them. No, we talked about a lot of things at this table. It was really hard, so we decided we'd go with Dr. Julie Wright's concept over here about creating learning and education centres, so on community-based learning, and linking in where Commonwealth Government and Department, so federal and NT Government already investing in growth towns or growth communities. They've already going to put infrastructure, so let's go back to the old way where we used to be able to do education, place-based learning. So that's where we came up with that centre. So we talked about a range of different things, but the cultural governance system actually needs to be driven by the community about what education and employment pathways they want, not driven by the opposite end, which is the RTOs, vet sector and university systems. So we talked a lot about that. We talked about flexible learning agreements, long-term funding, but also that the training and education pathways also need to be as flexible to allow us to have time out of community, out time of our study. So we know those of us that study and we have to take leave for cultural business, coming back into the education system's always got barriers, so we talked about that. And everybody kept saying jobs. So Jeannie's not here with us, but she talked about how 6 people in her community were trained up in ear health and there were no jobs at the end of it. And then what happens then with all of those people with all of the knowledge that they have? And then, as our corporate cultural knowledge holders who have been around for, I think we said 80 years between these two amazing ladies in the department. So all you students out there that are going to go work for NT, come and tap into these fellas' brains, because I swear to God, these ladies are amazing. But we talked about how come that knowledge isn't being given to the next workforce, and we're just having those same yarns over and over again. But the flexible learning, so Jeannie was sharing, the ladies that did that ear health training came up with the concept of job sharing. One do the morning shift, one do the afternoon shift, which would, suit. But then the barriers, and then Kim was sharing, she had heard about that stuff, but there's a barrier still within the system to actually enable that. And then on the ground, the ladies get humbugged. Well, why would I keep bothering? I'm humbugged now, I'm going to go look for another job or somewhere else. So then you've lost that opportunity. So if we create educational and learning centres that are governed by a community, then we'll have great outcomes for jobs at the end of it. One of the solutions. Anything else? Did I miss anything? No funding. And we're also going to go and see Linda Burney. So they wanted a photo, they wanted to rugby tackle her, but we're going to go see Linda with our concept and idea here at this table. Portfolio.
Okay, the next couple of tables, 11 and 12, they covered off the topic health literacy and health education among young people. So table 11, if you want to go first. They're all very shy. Come on.
Yep, I'm on. We talked about health literacy and health education among young people, and we felt that a solution was community-led yarning circles that talked about health and built health literacy. We felt that health education in primary school embedded in curriculum throughout the school years was really important, and improving health literacy through peer support groups. So for actions, we wanted to develop peer support groups, lobby government to fund grassroots projects for skilled staff, set up yarning circles highlighted by community, what they would like, how they would like to run them, who was going to participate, was it going to be different age groups attending, were there going to be male and female groups, were these yarning circles going to be family groups? And we thought it was really important to empower an community to identify their issues and goals that guided the yarning circles. We thought it was really important to create fun activities and content that was relevant to what was identified in the yarning circle. So potentially accompany this with playing sport, footy, arts as well. For key milestones, we measuring progress at 1 year. We felt like engagement in the yarning circles was going to give us a good idea if they were successful. Any identified issues throughout the yarning circles, participant feedback and satisfaction, highlighting a community champion, and whether any changes to the yarning circles were required. Measuring progress at 3 years, we felt like the same milestones should be repeated at 3 years, but have a bit of a train the trainer program for facilitating the yarning circles. Have an action plan that involved community members. And health sector actions that we've identified were having staff to commence the facilitation of the yarning circles. We need funding for the yarning circles that can then support community champions to continue those and ensure that they're sustainable. So we felt like as a health sector we could lobby governments and local members, create employment opportunities within our health sector, and develop partnerships and cross-sector relationships. We felt that the key decision makers were the community members. That included residents, elders, role models, as well as the health service, schools, shops. We felt like health is everyone's business, so everyone needed to be involved and in this partnership. We identified a few barriers for implementation of a yarning circle. Staffing can be thin on the ground. We need startup funding to ensure that we can commence. Weather sometimes is a bit difficult. If it's raining, it's unlikely a group can get together. If it's really hot, depending on which time of year you're running the groups. Being remote can be a barrier in itself, ensuring that there's sustainable groups running. And it can be quite time intensive to commence these groups. Getting groups together can take a bit of time. There can be shame and stigma, people being a bit shamed to open up, but we felt like there were examples already of groups that had commenced and shown that once people were participating, this shame and stigma was broken. And enablers to successful outcomes, we really felt like this had to be a community-led initiative with good partnerships. There needed to be family support, family involved, not just targeting people necessarily with certain conditions, family involved. Facilitating yarning circles in language and really empowering community to continue these.
Great. Thank you.
Cool.
And table 12.
Our group came up with a early intervention and education program targeting schools and family as first teacher programs, strong women workers, FPP. FPP stands for Family Partnership Program for pregnant women. The action, so the proposed action, I think we were going to lead with community engagement, so that stakeholder engagement, to find out what is working and what they want, what community wants. And when we talk about community, we're talking about community members and service providers, so it's sort of all those key stakeholders in community. Proposed action is to increase self-determination and confidence with positive messaging around prevention of diabetes, using local facilities such as pools, walking, and we were planning to embed CQI into the program. Preconception clinic.
That's okay.
Okay.
That's good.
Any more?
All good. No,
Want me to
that's
keep
okay.
going?
No worries. That's we'll get through the other tables as well. Thank you very much. Okay, table 13, because I don't think there was any on 14, was health promoting communities. We've got a spokesperson for that one.
Thanks. So with health promoting communities, the key themes I guess we talked about were food security and having a community that had the environment that had secure food options, and then we spoke about physical spaces in terms of sporting infrastructure, but also just general infrastructure like roads and things. And then we spoke about safe spaces, supportive environments that were culturally safe. So our three outcomes we came up with were that communities need to be enabled to be involved in establishing access to food secure environments specific for their community, so it needs to be community led. Community needs to be involved in establishing safe infrastructure, including physical activity spaces, so co-design with that as well. And then our third outcome was safe spaces and supportive environments in the workplace to increase local community staff.
Excellent, well done. Okay, moving on to table 15, community-driven resources and responses.
Hello? Yeah, so we discussed community-driven resources and responses. And our three key items were... quite a complex area and with lots of moving parts. But as sort of an overall statement, are dedicated structures and funding to enable meaningful and sustainable engagement. And we thought many things that are, I guess, already happening, plus a further strengthening of certain items. So that might involve the pathways to community control and how that might be further supported in, say, government clinics, in building up the local resources and governance structures that exist there, and supporting that with flexible work and training and remuneration that supports individuals to be champions within their community, and that will build engagement and drive resources. And then from the resources perspective, and building on the yarning circle and some of the suggestions here, there was a thought for consistent Northern Territory wide messaging. And we thought if that was easy to access for clinicians and across sectors, and available in simple English, and then sort of had a conceptualised tree that would kind of, I know this would probably be quite a big project, and trying to keep it all organised would be hard. And then a tree that would sort of spread out from that simple English resources to location-specific resources, champions, success stories that build on the strengths that exist and address the moral failure narrative and what the drivers of, say, diabetes and healthy lifestyle might be, if that kind of makes sense. And if there wasn't something for that region, it would kind of link you back to a cool toolkit that is easy to use for someone who maybe hasn't done that kind of work before, but is working in a community or in a certain setting, that could assist them with a community readiness assessment and possible actions and some ideas and how to just that process.
Excellent. Thank you. The next one, 18 looks vacant, so 17's got the gig for Housing for Health.
Yes. Yep. We did have health. Does it matter where you hold it? Is it better if you stand? Okay. We did have health and main outcomes. Sorry, it's going in and out. This way.
Oh, there you go.
Okay, I'll get up on stage now.
Come up here.
So our main outcomes were building and establishing a local trade workforce through increasing training and apprenticeships in order to empower the communities, consulting and engaging communities to determine the most appropriate type and design of houses. So that included ensuring that they are safe, sustainable, culturally appropriate and environmentally conscious housing. Obviously just increasing the volume of housing to match the need, which was a pretty wide goal. Advocacy for government accountability in public housing strategies to close the gap, and then lobbying for review and reform of council building standards to be more culturally appropriate and culturally informed. That was our main outcomes. I'll probably just wrote a lot of stuff. So.
Excellent. We'll be really looking forward to reading the rest of that. That's fantastic. Thank you. Okay, moving now on to cross-sectorial partnerships, 19 and 20.
This way, which way? This way? Okay. So ours is very long. I'm going to talk about all of it. So, cross-sectoral partnerships, even the title, Western. We started off with having a talk about how we can have intersectoral, what do we write here? Collaborations in prevention of chronic disease. And then we scrapped that because that's what we want to do, but we're not going to achieve that. Why? Because we need to decolonise systems and policies, especially at the top level. Our funding, our guidelines, and how we report. If we can't do that, we can't talk about anything else. Like Linda said and everyone else has said, we have systems who dictate how we do our jobs in our sector and also to the people who we serve. Our second one is around co-location. So once we've dealt with decolonisation, we...
Yep, we've done that. Okay, move on.
Oh, that'll take a year, yeah.
Well, that's okay. That was the first year. Then you've got the next 2, so you're all good to
go. So we've done this back to front. So I'm going to talk about all of the priority areas and then go into our actions, which are sort of 1, 4, 5, and then the last one, which is literally one sentence, 3 words. Decolonising. If we really want to see cross-sectoral partnership in a way that's working, that benefits community, then we would like to put forward co-location of different sectors for specific regions. So everyone coming together from different sectors in regions, because as we know, what works in Arnhem Land doesn't work in Central Australia. Improve the collection and communication of data across sector. I could give you examples, but I won't because that'll take forever. But this is talking about how do we actually inform our decisions? It doesn't, like we're all in health, but how do we in health inform our decisions for what the priorities of that community is or that region or whatever it is? We can't even get it right. What about all the other sectors? So there's all this, tools and systems we use for data. Again, it goes back to the system, the expectations, the guidelines that we follow. That doesn't give us a true picture. So once we meet in our region-specific areas, that is the focus area, is improving the collection. Because, again, who was talking about the... someone... Was it you, Renee? Or someone was talking about data before. And that data did not represent remote. And that's the same with ABS and our NT KPIs. The crosshatch that they put through and then it reads, please interpret with caution. Because they don't do data collection well and the systems that we have don't allow us to get the right story. So how are we actually improving diabetes? Fourth one is authentically community-led priorities and actions. I can tell you that I work in a big organisation and we are yet to get that right. And I am the person who should be talking about our priorities. But it's not my problem. It's the systems and the processes. So I've got all this big wish list, but I can't do it because the funding only tells me to do this. So I know there's buzzwords. We've been throwing around buzzwords. Community-led is one of them. We need, like, there is a better word, I don't know what it is, but community-led is what I'm going to use now. But that word community-led doesn't mean all of us. Doesn't mean me sitting in my chairperson hat in my organisation. Literally the people who live in the community. Number 5, last one is goals and outcomes that are based on goals and outcome-based funding. So priorities can be set at community level, not just a sort of like a one-size-fits-all from funding. So again, we get a bucket of money, gets put into our community. Some are relevant, funding sort of guidelines and tick boxes, but then some aren't. We literally tick boxes for the sake of funding. It's not aligned to our communities. Okay, that's enough of me going on about that stuff. How is probably what you guys want to hear. Anyone got pen and paper ready? So what are the actions to help us? Shared KPIs across organisations, sectors, and all of those Balanda sector-specific systems that we use right now that we want to decolonise. Health in all policies. Buildings that are co-located, that co-locate by community rather than sector. So having, H&M and Myers and everyone else is doing it, why aren't we doing it? They have one brand, then everyone sits under it. So we should be doing that for our community too. And then last one, establishing community-led forums to inform local, state, federal changes with regard to cross-sectoral solutions, develop KPIs and reforming structures that community are identifying. That actually was back to front, so that's the first one, that's number 1. And who is responsible for this? Not us. Community. Whole of community, not organisations. So we should be listening to community. And we should be prioritising how we do this work with what community is telling us.
Thank you. Now, just moving on to table 21, just with regards to peer and program support for social and emotional wellbeing. Oh, sorry. I missed your number. Yep, table 20, go for it.
I think Mel covered a lot of these, but so relevant and meaningful policy that makes a difference at the coalface was the first priority. Visibility of what's happening in diabetes from a clinical governance and a program perspective, and then flexible and holistic funding agreements and streamlined reporting.
Excellent. And Mel, I will come back to you after. Table 21, peer and program support for social and emotional wellbeing.
Yeah, so our 3 key outcomes included establishing genuine partnerships with community leaders to create culturally safe spaces, so both physically and emotionally safe. So really going along the lines of meeting people at the place where they need to be met. The second was investing in Aboriginal workforce as being key to effective support and engagement of these services and programs. And also just to note that that's not just the health workforce, that's also the community workforce. And the third was to implement and support existing effective programs across the Territory. And our actions include obviously having community leadership in all of our approaches, but to implement or to have a multi-sectorial partnership which is community-led to support and implement evidence-based programs and strategies that are both context-specific, acceptable and appropriate, and to ensure that all of those different strategies are being evaluated.
Excellent, thank you. And if we can just move to table 23, yep. Last but not least, cultural wellbeing.
Hi, so our table was cultural well-being, and I'm sure you can imagine that the conversations went well into lunch over this. So our top goals were cultural competency and safety training, health literacy being culturally appropriate, and developing a framework specifically to individual communities. From all of this, we decided that the best course of action would be to develop an cultural audit. So that's the purpose of ensuring workers are working with our mob appropriately and accordingly to local cultural protocols. So with that, so we talk a lot about cultural safety and being culturally appropriate. I think those definitions need to be put back into the hands of the community. They can tell you what makes them feel safe, what's appropriate. So with the cultural audit, it's about obtaining all that information. Coming up with a community-determined definition of cultural safety, what their actual priorities are, and then also just looking at the local clinics and sort of determining how culturally safe they are as well. So with the cultural audit, it's about developing a toolkit to help workers out there and workers who are going out there how to actually be culturally safe and culturally appropriate. And with that, that's about supporting the workers who go out there as well, because there is a level of cultural shock that happens. So if you get a fellow from Melbourne, bring him out to the Kimberleys, it's going to be very shocking. So it's about having support on that side as well. When we've also talked about building upon existing programs out there in diabetes. So in terms of cultural well-being, you take a diabetes program, maybe it's a cooking program, bringing in that cultural well-being aspect of it, maybe taking the community out hunting, take them out fishing, and then bringing them back to cook up the food that they have caught. The key decision makers are community elders and leaders, the services in community, and yeah, the key milestones are just developing that cultural audit. Thanks.
Thank you. Now that's all the tables. Mel, was there something else you wanted to add as well? Yeah. Yep, sure. Thank you.
Yeah. Oh no, just because I'm talking a lot, that's why I meant getting kicked out. I'm so sorry for taking up with 5 minutes. I will be quick. I wasn't here yesterday because I missed my flight because I had to travel 2,000 k's to get here. But I just wanted to, I was thinking about why I'm here and, why I needed to be here. And this is not a personal message to anybody, but I just want to share it because, we often are the decision makers for people. And particularly people with diabetes. Same story. I know yesterday you heard stories about people who live with it, people who are impacted by it, and their families as well. And I guess a couple of things that I really want to talk about that is important is we all have power. Whether you like it or not, we have power to influence what that person's life is going to be like, living with diabetes or even preventing people. So I came here yesterday, was supposed to be here, with that thought in my head, what do I need to do to talk about diabetes in my community and my people, and particularly in my family? One of the things that I thought is, why do I have to talk about diabetes? Why? Why are we talking about diabetes? Why aren't we talking about social determinants of health? We have been talking about it. So do we really understand social determinants of health? Why are we still talking about singular health issues when social determinants of health is not actually about diabetes? It's about the inequalities that make diabetes. I'm sure Marmot would be really proud of me and have me on his friend list because I read the first slide and I stopped at the line. Why do we treat people and send them back into the same environment that made them sick? Simple. So my role is not in health. And I want you all to take that back, because we have to unlearn to learn. I have to do that every day. I'm not a specialist in anything. I always learn new things. And that's the mindset that we need to have and go home with. And the second one is, none of you are allowed to leave here without an action. Because, and I'm not saying this particular one, but I'm sick of coming to events to talk about things that I'll come up to the stage. No, I'm coming up to my 5 minutes. I'm swapping mics. Yes. I'm sick of coming to events where, and I'm not talking about the actual event, I'm talking about individual people. Come to event, tick your PP box, tick your study leave, whatever you want to call it, write a story on Twitter, and then go back to your job. I want you to make an action for one person that you know, an Indigenous person in your community. Because I live with that every day, and I have to deal with that every day. So when I go back here, I don't talk about the forum, but I talk about people that I've connected, that I'm going to make a change. I'm going to do something. And you know what? White bread is off my shelf because I made that choice. You know, it's one little thing. But I want you to make a commitment to someone in your community that you work for. After this, you're going to go back and you're going to make that action work. Don't think of like big things like policy change and stuff. That's not going to work. But little things, something that you're in control of. That's all I wanted to say. And I know I missed that, and I'm so sorry that I took off 5 minutes. But that change starts with us. So if we're going to keep coming back to these events, I don't remember all of your faces, but I know that you're going to come up to me and say, oh, I met you here. And I was like, yeah, what was your change? I'll ask you. But we need to start with our community. We need to ask and we need to know what our community priorities are. Because like I said, even between my little communities, Irkala and the priorities that they have in that community are not the same as Gunyangara, which is 20 minutes from town. So how do you think when we sit in here, talk about, you know, all these changes we want to do, what are you going to do? They're all good ideas, but what are you going to do in your little sector, in your little clinic, in your little community? Start there, and then we'll start seeing change everywhere else.
Thanks, Mel. I'd agree very much. And one of the things I've always said is anyone's health really mirrors the environment in which they live. It really is, if we think about anything. So thank you so much. I think, give yourselves all a big round of applause for the contribution that you've made. It's been really valuable and will certainly help inform future steps. And I think, you know, as you said, Mel, being able to take one action back and actually put that into place, that's the foundation for change. And that's what we need to do, go there with purpose. Did you still want to ask a couple of people questions as to how they found the mind mapping process? Maybe not? Okay. No, that's all good. All those in favour of the mind mapping process, put your hand up. Oh, I've got an evaluation officer at the back. That's just what we need. Okay. Yeah, is there afternoon tea now? A group photo on the steps just before afternoon tea. That will be encouraging for everyone. So you have to be on the steps before you get afternoon tea. So if we can all go out, do you know where the steps are? Just that way. Great. Thank you all very much, everyone, and we'll see you on the stairs for a group photo.